Well, hello, everyone. Thank you so much for joining us tonight for the webinar, Robotic Surgery for Bladder Cancer. I'm Teresa Blondin, the Director of Volunteers and Programs for Bladder Cancer Canada, and I am so happy to be facilitating this session tonight. At Bladder Cancer Canada, we believe that education empowers patients. So we're thrilled to offer this webinar tonight, focusing on the cutting-edge field of robotic surgery for bladder cancer. And please remember that our webinars contain content intended for the sole purpose of information sharing and should not be considered medical advice. Always talk to your doctor and/or urologist about what is best for you. And if you run into any issues, myself and my colleague, Mary Lou Cameron, are monitoring the chat and happy to help. So now I'm honored to introduce our presenter for the night. Dr. Nathan Wong is a urologic oncologist at Fraser Health and a clinical assistant professor at the University of British Columbia. He completed a urologic oncology fellowship at Memorial Sloan Kettering Cancer Center and worked in New York as a urologic oncologist and robotic surgeon. He completed his urology residency at McMaster University, and his research focus is in urologic oncology and minimally invasive surgery. Dr. Wong, thank you so much for sharing your knowledge with us tonight.
So thanks again for the introduction. And like I said, I'm a urologist. I have a focus in oncology. And I think I kind of harbor a very interesting perspective for this. I trained in both Canada and the United States, and I also worked in both areas as well. And when I was in the United States, I did do a fair number of robotic surgery. And then so I was hired back into BC to help develop the robotics program at our center in Fraser Health. To kind of bring robotics to the forefront for our patients here. So we're expecting to open up our program this calendar year. So I was tasked to talk about robotic surgery for bladder cancer. And just a standard overall background for bladder cancer that most of you all know. It's a rather common disease. Every day, 37 Canadians are diagnosed with it. It's the fifth most common cancer. And it's usually diagnosed from the most common symptoms of having blood in the urine or hematuria. This is a very expensive cancer to treat because of all the follow-up and all the treatments required for us. And having robotics actually will add to that cost as well. And then also, it does have a high recurrence rate, but also a very decent survival rate if treated appropriately. And then so that's our overall cure. So this is a slide just taken from the website of bladdercancercanada.org. So these are the traditional procedures that a urologist will perform for bladder cancer, and I'm going to kind of hit through all three of them. There may be a few other procedures here and there, but these are the main ones and kind of go in sequential order. The first one's a cystoscopy. The next one's going to be a transurethral resectional bladder tumor, and the last one, which is probably the most exciting and up-to-date one, is radical cystectomy and robotics in that platform. And if I have some time at the end, one of my passions is also using artificial intelligence within urological practice. It's part of one of my passions in terms of helping clinicians run a more effective practice and have better patient interactions and managing their day otherwise. So if I do have some time, I can dive a little bit into robotics in that sense, or AI, artificial intelligence. So if you see red, see your doctor. I love this logo. I have a poster right behind me for my patients to see this and to understand why they're here to see me. And the reason why is that if you see red, it probably is a sign you may have bladder cancer. So the first way we diagnose that is doing a procedure called a cystoscopy. It's a mainstay treatment and diagnostic field for this. It's done usually under local anesthesia when the patient's awake. The urologist places the patient down, cleans the area, puts some freezing lubrication in, and places a very small fiber optic camera that's flexible that goes through the urethra into the bladder, and you look around to try to figure out where the blood is coming from. And what we really want to rule out is bladder cancer. So to the right, if you could see my pointer as well, this is what we actually see. So the urologist has to spend about, the bladder is not too large, so it spends about 2 to 3 minutes looking around the entire bladder wall and making sure we're trying to find something that looks like this. This is a very clear evidence of a bladder tumor. I say it kind of looks like either undersea coral or a sea anemone, or maybe even like an alien that kind of bulges out. And then, so our goal is to kind of try to find this. So how does robotic help us? So these are all different pictures of bladder tumors. Some of them are easy to see, like this one right here. And then some of them are a little bit more, and here's another one. And then some of them are a little bit more difficult to see without a trained eye. If you don't see a lot of these, which urologists do see a lot of, or if you don't have a lot of experience, it's kind of hard. And these small little areas could potentially be missed. And so our goal is not to miss tumors. So how do we do it? Very similar to try to figure out finding differences. So, can you spot the 10 differences in 27 seconds? So, as a human, I look for different things. So, you see this little red, this towel's missing some red things. The handle is green here, red here. There's water in this one. There's a D here, and maybe his shoes. He has some socks. There's a puddle on the ground, but there may be some things that I do miss. But maybe by using computers or AI, it can help to identify these areas more rapidly than a human can, at a faster ability and more accurately with less sensitivity. So this is where image recognition software, or in terms of the robotic platforms, can kind of play a role. And we use this in our day-to-day activities. Our phones will have this. The camera will face our face, and we'll recognize that it's us and unlock the screen. When you take pictures, it can group pictures into different themes, like these are sunsets, or these are your friends or your family, your children. It can use artificial intelligence to group pictures into different aspects. And in our sense, it could potentially be used to help see bladder tumors a lot more clearly. So, here's a tumor here that artificial intelligence can highlight. Here's a flat tumor right here that can easily be missed. Tumor on this side as well that looks a little bit more red, and this tumor hiding in the back right beside the scope. So artificial intelligence can help us play a role. So in a group in China did a multi-centered study to actually evaluate this out of about 6 centers, and they had over 70,000 images that they compiled of patients with either tumors or normal bladders as well. And they separated their data set into a training data and a validation data set to help train the machine into recognizing bladder tumors. So do note these are still images. It's not real time, but you compile a whole bunch of these data and you sort them out in different groups. And it actually showed, but after training these groups and validating with different data sets, is that AI outperformed the urologist into identifying tumors at a rate. With a diagnostic accuracy of over 97%, highly sensitive at 95%, and did it quite rapidly, taking about 12 seconds. So this is quite exciting. However, these are still images. So our real goal is to incorporate AI real time. So at the time of performing cystoscopy, have a computer connected to the cystoscopy machine to actually help to identify these areas real time. So hopefully we don't miss anything. And really, the goal is to identify tumors early before it starts invading or progressing, and therefore when we catch things early, we're able to treat them a bit more appropriately as well. So that's cystoscopy. And then so the next surgical procedure that we do is called a transurethral resection of bladder tumor. So after cystoscopy, we see the tumor. The next step is to do this procedure. And this is usually done in the operating room. The scope's a little bit larger, so it's a little bit more painful. And when you're actually trying to get rid of the tumor to resect it and remove it, that can be painful as well. Occasionally, I do this under local anesthesia or a spinal, or under a little bit of sedation. And the goal of this is by placing an instrument in and removing the bladder tumor completely. And this is not only diagnostic, because it gets you a sense of the pathology. So every single specimen we remove and we send it to the pathologist, but it's also therapeutic. So for non-muscle invasive bladder cancer, a good majority of patients will be cured by this procedure alone. The goals of the TRBT is to have a sense of the patient's bladder. So the urologist does an exam under anesthesia when things are a little bit more relaxed. You feel for the prostate, feel for the bladder to make sure it's mobile. Sometimes if you have a really big tumor, the bladder could be fixed. You do an initial mapping of the entire bladder, and you mark all tumors and you characterize them. And the goal is also to completely remove it, while at the same time sampling the muscle and ensuring that you don't actually go too deep and perforating the bladder. So it's a mix between trying to make sure you get the appropriate amount of tissue without causing harm or perforation of the bladder. So different types of bladder cancer. There's a non-muscle invasive, which majority of the patients are in. So that's CIS of the bladder, TA and T1, which is more, these are all the superficial bladder tumors. And then some can go deeper into the muscle layer. These are stage 2, 3, and 4. These are muscle invasive bladder cancer. And it's graded based on different pathologies. And the higher the grade, the worse the tumor is. And then so the goal of the TRBT, definitely these ones can be cured. So TIS, TA, T1 by resecting it. But you also want to make sure you don't have T2 disease, because these two are treated very differently. Non-muscle invasive bladder cancers can possibly be treated better with intravesicular therapies like chemotherapy or BCG, while muscle invasive may require more aggressive treatments like either radical cystectomy, radiation, chemotherapy. And that's why it's important to sample the muscle there and to completely resect what you can see. So that would be curative in the non-muscle case, and also not going too aggressive with the resection and causing perforation. So this is our traditional resectoscope. This is what we use to perform TRBT. It's a camera that's connected to a lens. That's a 30-degree lens, so you can look all the way around the entire bladder. And it's connected with a light cord to give us light, and an energy device to help cauterize and stop bleeding from tissue. And then this scope is called a continuous flow cystoscope, so it allows water to go in and the water to come out from the bottom end to allow constant irrigation. So if there is bleeding, we can see where it's coming from within the bladder. And there's lots of different devices we can connect to this. Typically, this is done with a loop that kind of goes in and out, and this can be rotated. So you have some degree of mobility using this resectoscope. And there's also other devices that you can use. You can use balls, burners, and buttons to just get coagulation. So the surgeon holds the scope with the hand and using a pincer grip, and then just moves this loop in and out, and rotates it around in order to get access to the tumor and resect it completely. So it does require some skill set to do. This is my TRBT. I just took this picture yesterday when I was in the operating room in anticipation of this. So this is the scope setup. This is a patient completely all covered. Can't see anything, but this is a patient lying down, and this is the scope that we see. That's the loop, and this is where the tumor used to be, and it's completely removed, and this is what the muscle there looks like. So no perforation here. It looks really clean. I went all the way down to the muscle there, so I'm very happy with this case. And then the conventional TRBT is you use this loop in and out to kind of scrape the tumor, and these floating tumor cells are flushed out. And you want to make sure that there's no evidence of any more residual disease. But this is actually one of the only tumors that we kind of do this in. And interestingly, for TRBTs, what you do is you just kind of scrape the tumor all the way towards the bottom. But sometimes it may not make a lot of sense, because if you scrape the tumor, maybe these tumor cells might start floating around and may potentially reimplant, lead to recurrence. Or you may accidentally leave some tumors behind if you don't do a full scraping and remove everything. So a new technique that's gained a lot of traction over the past 5 to 10 years is to do something, if feasible, is to do a transurethral en bloc resection. So instead of scraping the tumor, kind of shaving it from top to bottom, you use the scope to kind of peel off the tumor from the bottom while making sure you don't perforate, and then you have a floating tumor all intact, and then you suck that out to remove it. And this was a randomized controlled trial that was actually published late last year, that showed that this was rather beneficial in terms of it had a lower recurrence rate of the tumors, because you weren't leading to all these cancer cells floating around and reimplantation, leads to a lower progression rate, better sampling of the muscle. However, it did take a little bit longer to do this procedure than the classic scraping. So it does have its risks and benefits. I tend to do this as much as I can, if technically feasible, but it is sometimes very difficult to do with an instrument that just kind of goes in and out and can kind of just rotate. So how can robotics help? So this is a new device that's in development by Virtuoso. It's been I saw a few videos of this at a few of our international meetings. It's definitely not standard of care, but this is a device that goes transurethral in. And as you can see at the bottom of these little of the scope, instead of having a loop that kind of goes in and out, it has these two little fingers or hands. And so at the end of it, it's like having two little hands on the inside that can help to do the surgery with a bit more mobility and a bit more precision, potentially. And then so I do have a video for this that I'd kind of like to show. So this is the video from their website. And then, so as you can see from this, with these two instruments, this is a bladder model. This is at 4 times the speed, so it's a lot faster. But what you can do with these small little hands is actually put your hand, it feels like you have your hands inside, and you can slowly make sure you sample the right areas and to remove the tumor from the very bottom. And you have a lot more mobility of it to remove it completely, to hopefully do this on block, and hopefully that prevents further progression or and recurrence as well. And so this is the video as well. It's not yet approved yet. It's currently within clinical trials, or about to start clinical trials to determine its efficacy. But this is one application of where robotics plays a role in TURBT, or transurosectional bladder tumors. So I'm just going to go back to my slides. And then this is another system that's being developed as well. And this one's slightly different and slightly more interesting. So this is called a TUR bot, so a robotic TURBT. And then so this device is very similar. The scope kind of goes into the patient, but instead it's like it deploys a snake that can kind of move around within the bladder and they report of having 70 degrees of freedom in terms of moving within the bladder, so you can access every single aspect of the bladder wall. So it's connected to this robot, which is controlled by the surgeon, who's at a console, and this is just a model that they're doing to study it. And this is still, again, experimental, not standard of care to do. This is a pilot that they did with some animal models. And this is the device that allows movement. And so this is the model that they have. They're deploying the snake, and it kind of goes on the inside, and it can move all the way around, can look left, look right, and look completely back on itself. And it's fit with a camera, a cautery fiber device, a biopsy device. So it's able to do a lot of things within this scope. So instead of just a loop that goes in and out, there's lots of mobility with this, and that's very exciting, potentially for our patients. Here are some more images of this TUR bot, and with its multiple arms and functioning, it's able to do several things like biopsy, laser, and to get rid of and treat the bladder tumor. So those are all the experimental things that are kind of going on. Then there's probably they're in the pipeline. They probably will start making their way within the market in about 5 to 10 years, probably in the States. Canada usually is a couple years behind in the States in terms of adopting new technology, mostly because of our healthcare system and the payer model that's associated with this. The next thing I want to talk about is radical cystectomy. So this is really the gold standard for muscle invasive bladder cancer. What this involves is removal of the bladder. In men, it usually includes the prostate. You can do a nerve sparing to help preserve erectile functioning, and sometimes in some patients, I do preserve most of the prostate as well to help maximize that. Also removes the seminal vesicles, the vas deferens, and then the lymph nodes on both sides. And in women, it's the bladder as well. Sometimes it includes the uterus, the ovaries. These are usually spared in women of reproductive ages, or who the ovaries are still functional. The fallopian tubes and the anterior vagina is sometimes spared as well to maintain good sexual functioning, and then lymph nodes as well. So you remove the bladder, then now what? So the urine has to go somewhere. Back in the day, we used to put the ureters directly towards the skin, but these tubes are very, very small. So what happens if they just go towards the skin? They will narrow and they will block off and they will scar down. So instead, what we do is we usually harvest a piece of the ileum and reconnect it back together. And then we connect the urinary system towards this ileum, and this is what becomes our reservoir. Radical cystectomy, very interesting operation, one of the more complex operations that urologists do. And it's very interesting. It's not only, you're removing organs for cancer control, but it's such a significant reconstructive. You're creating a whole new organ, like a new bladder or a new thing to control urine. And there's lots of potential issues with that as well that leads to this being a complex procedure that we really need potentially use robotic help for. The bowel is not normally supposed to touch urine. The function of urine is to get rid of toxins. The function of bowel is to reabsorb nutrients. So when urine gets in contact with bowel, there can be some metabolic issues of that as well. And with anastomosis, when you do harvest a piece of the bowel, there can be some bowel complications with a radical cystectomy with that as well. So what are our options now that we remove the bladder? So if we harvest a small piece of bowel, we could connect it towards the skin, and that can come out through a stoma. This is something called an uro-conduit. This is probably the easiest one to do, the simplest to do, because you harvest just a small little tube that connects towards the skin, and then the bag is on the outside. So this tube is always draining urine. So urine collects on the outside. And then so there's no need to catheterize anything or to hold urine, and it's not continent. So therefore, because of the minimal urine contact time towards the bowel, this is very well tolerated by patients. The unfortunate thing is that there can be some body image issues by having a conduit on the outside. I would say about 60 to 70% of patients end up choosing an ileal conduit as their main option, just because of the recovery time associated and the minimal issues associated with this. Another option too is to do a neobladder, and this is where you connect the kidneys towards a new piece of a longer segment of the ileum that's folded into a ball, and this stores urine. And then the patient kind of voids quote normally, but it's never really normal because it's a piece of bowel instead of a bladder, which is a muscle that's inert. So when urine contacts a neobladder, some of the urine can be reabsorbed, leading to some electrolyte abnormalities and whatnot. So it's a little bit more complicated procedure. Usually in my hands, it takes about an hour or two longer than an ileal conduit to perform. So patients, about 20% of patients will choose this option. And another one is an Indiana pouch. So this is where the neobladder is not going back to the urethra where you pee out of, but just through a stoma through the skin. And then so this is just catheterized. So instead of having a bag that's constantly draining, there's a valve here, and then the patient needs to put a tube or a catheter in there in order to drain the bladder about 4 times a day or more. So this is a big surgery. It's a gold standard, but it is invasive. So this is one of the most well-documented series of radical cystectomy. This was done at Sloan Kettering, where I trained, evaluating this procedure over time from 1995 to about 2005. And this is a high volume center, which does a lot of cystectomies. And even when they do a lot, you can see how the percentage of complications. So the percent of about 2/3 of patients will get a complication from this procedure. You'd be lucky if you didn't get a complication. And when we grade complications, it goes on a scale of 1 to 5. So 1 are easy ones to kind of manage. So about, in terms of the 0, so no complications, about 36% of patients don't get a complication, and the rest do get a complication, ranging from very low complications, maybe like a fever or a wound infection that doesn't need an operation. Usually a grade 3 complication does require a repeat procedure. So that happens or a procedure or something to fix. That happens in about 12% of patients. And a grade 5 is death. So there's a 2% risk of death with this procedure within 90 days. What do these complications usually look like? They can be usually gastrointestinal. So this is a very unique surgery where you're connecting urine into the bowel function. So you can have ileus, small bowel obstructions. You can have infections like fistula, like abscesses, UTIs, wound infections, renal failure, cardiac issues, heart attacks, strokes, blood clots, and those are usually the things can be life-threatening, like a blood clot that you have, and that's like for these patients. And then, so how can we do better surgery? So usually for a radical cystectomy, when we do this open, it's done through a lower midline incision, so from the belly button all the way down, and that's how we access the bladder and the pelvic organs. But the aim of minimally invasive surgery is to help improve patient outcomes. So instead of a larger incision, you place smaller keyhole incisions that are about 1 centimeter in size. And hopefully the goal is with smaller incisions, patients have less pain, there's more precision with the instruments, less bleeding. And because of all this, of all these lessons, the goal is a shorter hospital stay and a faster return to activity. So less pain from a larger incision by these smaller incisions. And typically this is done, minimally invasive surgery is done laparoscopically. So these are cameras with lenses that you attach a camera to and a light cord to see on the inside. You insufflate the abdomen with air, and you place these ports or trocars in that allows you to access the abdomen and pelvis. And all these instruments they look kind of like chopsticks. They're like grips that kind of open and close, and you're able to have different types of attachments to them, either graspers, scissors, needle drivers to do sewing on the inside. And this allows us to do surgery through smaller and smaller incisions. So for cystectomy, it's feasible to do it, but it's quite technically challenging. There's lots of steps for a cystectomy. You have to move around a lot. So not only you have to work in the pelvis, but then you have to shift to remove the bladder and maybe the prostate or uterus. But then you have to shift upwards to work on the abdomen to harvest the piece of bowel that you're going to connect your urinary system to. And in addition, there's lots of sewing with a cystectomy in terms of reconstruction, connecting the ureters towards the urinary diversion of choice, whether it be a conduit or a needle bladder. And then laparoscopic sewing is notoriously difficult. You can imagine trying to sew with 2 long chopsticks, of how difficult that could be, and making sure all your suturing is very precise. So it's a very technically demanding and challenging procedure. I do a lot of laparoscopic prostatectomies, and so there's lots of sewing for that, and that causes a lot of shoulder. Like at the end of the day, I really feel it in my shoulders after doing this procedure. And therefore, this is when robotics kind of plays a role to help improve our outcomes in terms of and improve the ease and learning curve of performing laparoscopic surgery. So all robotic surgery for within the abdomen or within the pelvis is called robotic assisted laparoscopic surgery. So you use all the principles of laparoscopic surgery, but with the help of a robot. So instead of having to stay the surgeon's bedside, and holding all the cameras, instead, robotically, the surgeon stays in this device, which is a console. So it's kind of like playing a computer game where they look into this device, and there's a console here with some graspers that the surgeon moves around. And then what happens is the robotic device bedside does all the motions that the surgeon does right beside the patient. This is really interesting because there's this distance here. This is really interesting things of we could potentially use that. The initial robotics were designed actually for like war, where you do surgery was very remote from where the patient was. So in areas of trauma or the battlefield. So this leads to a lot of like telesurgeries that could potentially happen, but you do need strong fiber optic cables in terms of making sure there's no delay from what the surgeon does and what the robot does as well. So there are some videos.
Limitations of conventional surgical technologies. 3 network components comprise the Da Vinci surgical system: an ergonomic surgeon's console, a patient-side cart with 4 interactive robotic arms, and a high-definition 3D vision system. Seated at the console, the Da Vinci surgeon views a remarkably clear 3D image of the surgical field. The system scales, filters, and translates the movements of the surgeon's hands on the master controllers to 4 interactive robotic arms on the patient cart. The precisely controlled micro-movements of the Da Vinci instruments are enabled by the computer processors of the system. These dedicated processors perform millions of safety checks over the course of a procedure for enhanced surgical precision and control. Da Vinci EndoWrist instruments are designed with a unique wristed architecture that provides 7 degrees of freedom for a range of motion greater than even the human wrist. This proprietary design enables surgical maneuvers impossible with conventional laparoscopic tools. The system requires that every surgical maneuver is under the direct control of the surgeon. Redundant safety checks prevent autonomous movement of the instruments or the robotic arms. The Da Vinci S surgical system moves surgery forward with a new level of technical capability that enables minimally invasive surgery in complex procedures as never before. Da Vinci provides a streamlined surgical experience that benefits the hospital, the surgeon, the OR team, and, most importantly, the patient.
So that was the Da Vinci system. The other video was just, it's a very popular video of peeling a grape using this device. But the Da Vinci system is probably the most common platform used within Canada and worldwide as well. There's a few other platforms that are on the move. There's a Hugo Ras system. China has a few systems that they're using as well, and then. So it's going to be great as more and more robotic platforms get on the market to help. Hopefully, also, I'm on a lot of committees to try to bring robots to many hospitals, and so trying to get that price down point. So it's great to have competition within that field. So these are kind of the aspects of the ones of the robot system that I like the most. You saw that endo-wrist technology. So instead of laparoscopic surgery, where it's like chopsticks that kind of go in and out, you can actually feel like you have your wrists on the inside. Laparoscopic surgery is done with 2D vision, so you can't really see depth very well. You have to have a good sense of visualization to actually perceive what depth is. But on this robotic system, it's like watching a 3D movie. You could kind of see things in and out in different planes. And then the surgeon itself also has 4 arms. So the surgeon controls all 4 of those arms, the camera, and then the 3 working arms. So it's like you have, instead of 2 arms, now you've doubled the amount of arms that you're able to work and maneuver with. It shifts back and forth. So lots of great things in terms of making minimally invasive surgery easier to perform. There's a few other robots that are coming out from Da Vinci as well. This is their single port robot. So you saw back here, this is their what they call the multi-port system, where there's 4 arms. So this was the robotic system that I kind of talked about, the endo-wrist, 3D vision, and control of 4 arms. And then this is the single port arm. So this is probably developed about 5 or 6 years ago. It's used at probably about a dozen or so, or maybe about 20 or so places in the States. So instead of having multiple arms and multiple incisions, you make a slightly larger incision, and then all 4 of those arms come out from that port. So it's slightly bigger port at one site, but it's all gone through one single incision. So instead of multiple incisions throughout. Most of the data for this shows not really a great benefit of this compared to the multi-port system. You do have a single incision versus multiple incisions, so there's a cosmetic aspect of it. But to use this one, instead of a lot of hand wrist movement with the multi-port system or the Da Vinci Xi, this requires actually a lot of shoulder work for the surgeon. So it takes a little while. I've done this. I used this a few times on cadaver models, and it works slightly differently, but it's very interesting and very cool. So it looks very reminiscent to the TRB-yacht system. And then, so the big challenge is laparoscopic surgery is notoriously difficult to do. It's a lot of strain on the surgeon, and it does require a lot of cases to kind of get up to that, and because it does require a lot of technical expertise. And for example, doing a laparoscopic prostatectomy, literature shows that the learning curve for this takes about 400 to 700 cases in order to show that your complication rates are stable and your margin rates are low. You make sure you get all the cancer. Versus a study that I did looking at robotic prostatectomy shows that using the robot, you actually need less than 100 cases of this. And this is a study that we did when we were at McMaster, but looking at this. So the learning curve with robotics, it's a lot more intuitive to do, easier to perform. So even using this device, it makes complex surgeries a lot more easily able to perform by all surgeons, not just select surgeons who have a high volume for this. So it helps to provide care and to a greater proportion of patients. And So this is our robotics team when I was in New York. We used the multi-port system. It does require a team approach. You know, it's not just a surgeon, but you have people at the bedside, nurse circulating, transitioning different arms, and making sure that the robot functions appropriately without any sort of hiccups. This is a model that we created to help teach how to do robotic surgeries for either a neobladder or a prostatectomy. So one of the most difficult parts of doing a neobladder for a cystectomy or doing a prostatectomy is connecting the urethra back towards, or connecting the tube back towards the new bladder. So this is a 3D printed model that we use to help, that we created to help teach trainees how to perform this difficult procedure. And this is one of our publications at McMaster. And we actually started showing and create a curriculum of using virtual reality simulations systems to teach trainees, including medical students, residents, of how to use the robotic platform in a safe manner. So instead of operating on patients, is working on these virtual reality simulators, and then getting a sense of how to use the robot. So, you know, different tasks like dropping pins in here, burning and cutting, and doing some sewing as well. And then we translated that towards our 3D printed model that I showed previously, and showing that by creating a standardized curriculum, the outcomes in terms of doing this 3D printed model was more and more successful, even with individuals with almost zero robotic training before. And then we actually extended this even further to develop a boot camp for residents in terms of going through. So this virtual reality simulation platform was kind of used to help teach residents through a more structural approach. So robotic surgery is on the rise worldwide. You know, urologists were initially at the forefront of robotic surgery, and this is actually when I first got introduced into urology in about 2009. That's when I graduated from my undergrad, and I got excited into medicine. And when I was a lot younger, I was really interested in technology, video games, and robotic surgery really kind of spoke to me, and that really drove to my interest without this. So urology was a field that played one of the largest roles within developing the robotic surgery platform, and still kind of does. And as time goes on, at least in the States, or worldwide, robots are becoming more and more readily available throughout. And these are actual cases that are being performed, and it's spreading through other specialties as well. This includes cardiac surgery, colorectal surgery, general surgery, gynecology, head and neck, thoracic surgery, and urological surgery. So this is what we do, and this is cystectomy as well as is in this network. This was back in 2017 when I was at McMaster. We were published within the Golden Mail of trying to push for robotic access throughout the country. Unfortunately, most of the funding for robotic platforms are by donation and through the foundation of the hospital. And then so it's really hospital based, of which hospitals do have access to a robotic platform. And so we thank everyone who donates to this cause. Within Canada, robotic surgery is on the rise. This was, I believe, 2015. Most of the robotic platforms are situated in Ontario and Quebec, some on the East Coast, and then on the West Coast as well. This is Vancouver at VGH. This is Calgary and Edmonton. But as more and more time goes on, more robotic platforms are being added. Victoria and BC recently got a robot. Saskatchewan, Manitoba, in smaller areas within Nova Scotia, New Brunswick are getting platforms as well. So it's really expanding. And this is my center right here at Royal Clement Hospital in New West in BC. We're set to get our robotic platform later this year. In terms of radical cystectomy, I do have a video for this, but maybe I'll just skip it due to time. Because I do want to leave some time for questions. But this is a nice website that I could link towards. And then so this is an actual patient. These are the robotic arms on the inside. Here's the bladder. Here's the vas deferens. Here's the rectum behind. One of the arms is holding the bladder upwards, and then these are the working devices that the surgeon controls on the inside in order to do the surgery. To teach really robotic surgery, it's really a structural approach. There are some easy steps in terms of developing a training curriculum. That includes just placing the trocars and putting the specimen in the bag, to isolating the surgery, and then more complicated ones like actually doing the bladder resection, getting the ureter mobilized, and then particularly one of the harder parts are harvesting that segment of bowel that's used to connect the ureters into that. So the ureteroileal anastomosis. It's like sewing some very small tubes into another tube. And so it's very complex surgery, and that the robot is very useful for it. Here are some cartoons about how to harvest the piece of bowel for the diversion. So here's a stapler device, and then stapled back together to reconnect the two ends of the bowel for the segment that's harvested. And one of the more complex procedures to do for this is the neobladder. So this is the urethra. We're looking down towards the pelvis. So you take this piece of bowel, you move it down towards the urethra. You sew the urethra to an opening of the new neobladder, so it requires pinpoint control, and it's very small sutures that are connected. And these suturing also needs to be watertight. You have to want to make sure that there's no urine leaking out and things heal very well. And then you detubulize the piece of bowel, because if a bowel is in a tube, it's not like a ball. You really have to fold the piece of bowel into a ball. So you make an incision all the way across, and then you cross-fold it. You sew the posterior plate, and then you flip the anterior plate over it to make it into a ball. And then you connect the ureters into that segment over some stents. And you can see lots of needles, lots of sutures, here, there, stents, wires. So very complex to do laparoscopically, and the robot platform really helps doing this procedure. So how does open surgery look a surgeon compared to a robot doing the surgery? Well, actually, a robot doesn't do the surgery. The surgeon controls the robot who does the surgery, but still, this is a cute little cartoon. In the US, there's been a slow, gradual rise for robotic radical cystectomy. So 2002, all surgeries were done open. And as the platform became more and more available over time, you can see the robot surgery starts to eat a bigger share of all the cystectomies that are done robotically. Probably right now, about 30 to 40% of these cystectomies are done robotically in the United States. And one of the main issues with robotic surgery that this paper kind of looked at in terms of the data set showed that you had really pretty similar outcomes comparing robots. So that's the first column versus open surgery. In terms of the outcomes, maybe a slightly fewer infection rates, but otherwise the complications were pretty comparable. But interesting things to note is that the hospital stay was shorter, although by a day. While the issues with return to hospital were somewhat similar. A main difference was the cost that you can see here. So the robotic surgery platform cost the system about $3,000 more per patient. A lot of it is saved because you do discharge patients a little bit faster, but the platform itself is quite expensive. So it's you're costing about more than 15% more per patient by doing a robotic surgery rather than an open procedure. Retrospective data showed that robotic surgery, again, was associated with a shorter hospital stay and as well as a lower complication rate compared to open counterpart. But this is just looking back at your data. So there's a lot of patient selection here. So mean hospital stay in this series was 2 days lower. Blood loss was 500 cc's or half a liter less. Transfusion rates were 30% less in the robotic group versus the open group. And the complication rate, at least within this group, was lower, but still a very morbid procedure. At least about 50% of patients do get some sort of complication and even a risk of death in that robotic arm that you see right here. So grade 5 complication right there. So still, even though you're doing robotic, it's still a big procedure to do. This is a randomized controlled trial. So patients were randomized, a group of patients were randomized, and this was done at Sloan Kettering, where I trained at, to either having robotic surgery or open surgery. And when you actually randomize patients towards these two, so you remove any selection bias, sometimes you may select, hey, this is a very healthy patient, let's do a robotic surgery on them to get good outcomes, like the previous paper potentially could have. This kind of mitigated all that selection bias. So it actually showed very similar complication rates between robotic and open, no huge difference. The only thing that this group did show was that robotic surgery did take a little bit longer to do, and that makes sense because you have to dock the robot, put all the ports in, rather than open surgery, just make an incision, the surgery gets started. But they also did notice, like the other paper did, less blood loss as well. This is another randomized control study done in the United States, and pretty much it showed that robotic cystectomy was safe. Anytime we do introduce a new technology, you wonder, are you causing potentially some harm? Are you at more risk of causing the cancer to spread or recurrence? So this looked at progression-free survival after surgery, and it was the same whether or not you had robotic surgery or open surgery. And then this is a study that really looked at recovery after. This is a randomized control trial that looked at recovery after robotic surgery versus open surgery. And it showed that patients undergoing robotic surgery recovered faster. And then the way they measured it, they used this funny way of measuring it as number of days alive out of hospital was higher with robotic surgery rather than open surgery. So patients got home sooner, less likely to come back to hospital or be readmitted, are less likely to have complications associated with this. So this is a push of why robotic surgery leads to faster recovery. And this is the IROC group in the UK who published this. They looked at their recurrence rates, very similar. And then again, they looked at their complication rates, somewhat similar. And again, this is still, although we're doing it robotically, it's still a morbid procedure. 66% complication rates, including a 2% risk of death here. And these are their complications that they noted. Very similar to what we highlighted before. And then so a new Da Vinci platform that just got announced last year is the Da Vinci 5. And this actually integrates AI and helps a surgeon perform better surgery kind of real time, get insights into it. So this is a new platform. A few centers in the United States have started using this. Nowhere in Canada has started using this yet. But the point is to use AI to help measure the surgeon's movements during it and look at their economy of movements, their instrument path, their clutching, to help give the surgeon real-time feedback of how to do the surgery better and better by comparing it to other surgeons worldwide who are also locked in. And then so this gives a better sense of a knowledge of the skill set, and by this is real-time learning, so you kind of get better each and every case. And so this is really going to drop down that learning curve even further. There's some robotic platforms that are completely self-autonomous. So this is all experimental, about using robots to do it without the control of a surgeon. And this maybe I'll be out of a job in 20 years when this becomes more and more mainstay. Just going to check time-wise. I should probably end shortly. I do want to just quickly go by a few things. So this is the application of AI within urology. In terms of bladder, it's a little bit missing within the surgery aspect. Most of the data is within diagnosis and trying to predict recurrences. Very heavily within kidney, where you're using a lot of markers or a lot of to find kidney tumors. AI can help improve a lot of patient outcomes. So robots can improve not only just the technical aspects of surgery, but showing efficiency of movement and economy of movements, but also in drug development, helping to predict care. So we used when in healthcare, we used machine learning algorithms to help predict recurrences after surgery and how we can help patients make the right decision. One thing I quickly want to just talk about is AI within the office. This has been a passion of mine. And this, I've been asked to give a number of talks within our urology groups to help integrate computers within our office models, not only just within the operating room, but within our office. And one thing that strikes me or strikes a lot is the burnout within physicians. And then interestingly, this is a publication from Medscape that showed that urologists were actually the top physicians to undergo burnout because of usually because of the work or the amount of work or different aspects of the disease, sometimes dealing with cancer and other aspects of patients' life. This is a report done by the AUA that surveyed urologists. That's about 70% report some sort of burnout. And then usually it's due to some sort of administrative burden or technical challenges, patient expectations, reimbursements, or policies. And what I really like to target is the administrative burden and technologies, because I've been really interested in technology. And what constitutes burnout is usually two main bureaucratic tasks like paperwork and charting. And then so one thing that I've tried to champion within the urologists in our area is making use of medical technology and robots within our office to help the system, and then using AI scribes. So this way, instead of, at the end of the day, before using any of these AI scribes, I would talk to patients and then write notes, and then at the end of the day, I'd spend 1 to 2 hours longer to document. I'd be sitting at home right after eating dinner or eating dinner and doing charting in order to do all the documentation that needed. But using AI in the office, after getting patient consent, you actively record the conversation, and it records the information provided from the notes that come in from the conversation with patients. And instead of working on your computer and while talking to patients, you can actually I feel like now you could actually have a conversation with patients because all the charting is done autonomously. It helps with communication with other surgeons, and it is also useful for different languages, easily translation to Spanish or Mandarin. And pretty much what it does is it records it and it creates all these templates to allow communication and really cuts down on burden. So I'm going to end a little bit early. I went a little bit over time. I just want to see if there's any questions from the group. I know my throat's a little bit soft. Hopefully everyone didn't get too lost for anything.
Oh, that was great. Thank you so much, Dr. Wong. So much exciting developments with technology. It's awesome to see. So we'll open the floor to questions. You can type anything in the chat box and I can read them out to Dr. Wong. So first question, how soon do you expect robotic surgery to become a routine procedure?
So for cystectomy, it's getting a lot more routine. Probably about 30% is done in the United States. It will never be all 100%. It's all an issue of access. So like when I'm looking at this webinar chat, I don't see the other chat room, but I see a webinar chat. Seems like a lot of people are in BC, in my neck of the woods. There's only one robotic platform right now. That's at Vancouver General Hospital. Or actually, I just mentioned Victoria got one. And we're getting one this year. So it's going to take time for hospitals to kind of build and to understand that this is something important to both clinicians and patients. And maybe it is worth that extra $3,000 to do this case in order to get patients home sooner, out of hospital sooner, helps with congestion. Will there be zero, training residents? They're getting really good at using the robots because that's what they were trained. I was trained at a very unique point of time where robots were just getting more and more readily available. So half of my training was done doing open or laparoscopic surgery. The other half was doing robotically. And in the States, I did everything robotically. So I still have technicals and expertise in different things, but down the road, everyone's just, at some point, all the trainings are just going to be robotic trained. And when I was an academic in the States, when I was teaching residents then, they were all doing everything robotically, even cases which, in Canada, you would kind of laugh a little bit about like, why are you doing this robotically? This is a fast case, it would take 20 minutes. We could do it laparoscopically. You don't need to spend the money. They were doing them robotically just because you use the tools that you're comfortable with. you use the tools that you're trained with. And I think out of anything, one of the takeaways that maybe I wanted to stress that I didn't stress, it's I wouldn't really worry too much about the technology as much as I would worry about the surgeon doing the procedure. Because in the end of the day, you want to make sure that this is a tool that a surgeon's comfortable doing and to get the good aspects. You don't want a surgeon who doesn't do a lot of robotic surgery to just jump on a robot and doing the surgery. That definitely would not be a good idea. Nor would you want a surgeon who does a lot of robots to just start doing the open technique. So I would say out of anything, that most paramount is that you're comfortable with your surgeon and your surgeon has that expertise, rather than seeing if robotic platforms become more widely available. But it is coming. I think in about 5 years from now, even smaller hospitals are going to start getting it higher access to it. It depends on how successful other areas are. So we're looking very closely at least in BC, at Victoria, of how successful they are with their program, and we're going to be looking towards our program as well. I belong to a part of the CUA Community Urologic Association, the community group, and smaller and smaller centers that are not even academic at all are having robot systems available, and then so it's going to be it's going to take time, but at some point this will become standard of care. When that's going to be, we're usually about 5 to 10 years behind the United States, and they're probably about 30% right now. It will slowly get higher over time. So I would presume maybe 15, 20 years down the road, it will be probably the standard.
Okay. And if someone prefers to get the robotic surgery, is that a possibility to ask their current urologist for a referral to someone who is trained on that?
100%. And that's the great thing about healthcare is that there are options for everything. I refer a lot of patients right now towards our local center who does a lot of the robotic platforms right now. When I was training in Hamilton, there was a huge referral patterns to us there because we were one of the highest volumes for robotic centers, or robotic surgeries there. Me and my mentor, Dr. Shagan. So it's definitely the biggest thing that I get a feeling, at least right now, is access. So the robot can only work, there's only one robot at some centers, and wait times for some surgeries can be quite long and can be 3 months, 6 months, even out to 9 months later. I would say for bladder cancer that it's probably something that you shouldn't wait unless it's pre-planned. One thing is considered for cystectomy is if you're getting chemotherapy, that's going to give you about 2 to 3 months lead time, and you'd want to recover from chemotherapy too. So that would be, I think, my ideal candidate to actually get on that wait list. And by that time your chemo's done, you recover from chemotherapy, you have a date for your surgery. But if bladder cancer is not something you really want to sit on, particularly muscle invasive disease. Without any sort of treatment, muscle invasive disease tends to spread to other parts around the body, about 50% at about 6 months. And once it spreads, it's no longer curable.
Yeah. Okay. And it looks like last question. You mentioned that the robotic surgery takes longer. How much longer?
Yeah. So in the data that I showed, it takes probably about probably about 45 minutes to an hour and a half longer, because it takes time to put the ports in, to do that safely. It's done under direct vision. You also have to bring the robot platform in, connect all the arms, and then sometimes the camera gets smudged, and then you have to clean the camera, take it out, clean it. You have to switch different arms, rather than if you make an incision, it's a lot faster. I would say when I did this in New York, it would take me about 3 to 4 hours, probably about 4 hours on average to do. And then now when I came back here, I transitioned back to doing open surgery. It takes me about 2 to 2.5 hours to do a cystectomy, skin to skin time. So there is that time it kind of takes. And when I was in New York and doing robotic surgery, that's when I started becoming an independent practice. So I was still developing my learning curve for that at that time. So I think as time goes on, those curves will get faster and faster. I'm at later stage in my career, I know my anatomy. They say surgeons kind of peak at around 5 to 15 years outside of training. That's when you have the expertise, you have the anatomy, you've seen complications, and then so it very depends very, but on the data, maybe about 100 minutes or so.
Well, it doesn't look like we have any more questions. So I hope everyone enjoyed the session tonight. We have quite a few education events coming up, a live workout in March, an in-person education event in Vancouver on May 14th, and in May, sexual differences in bladder cancer. So you can register for all of these events on our website under patients, upcoming events, or you can scan the QR code on the screen. And the sex differences session is not available to register on the website just yet, but Mary Lou will share a direct link in the chat right now if you would like to register tonight. So after the webinar, a survey will pop up in your browser. We'd love to hear your thoughts on this session and any suggestions for future presentations. So please take a few minutes to complete that survey, and it will also come via email tomorrow through Zoom. If you would like any accommodations to complete the survey, or if you have any additional comments or questions, you're always welcome to call us at 1-866-674-8889 or email info@bladdercancercanada.org. And Canada Walks for Bladder Cancer is celebrating 15 years, and we hope you will join us. For 15 years, participants and supporters have helped improve the lives of those affected by bladder cancer by raising $3.2 million for research and support programs with the goal of improving outcomes for every bladder cancer patient. So we hope you'll support the work that Bladder Cancer Canada does and help us raise awareness of bladder cancer by getting involved. You can register, volunteer, or donate. It all makes a difference. So visit bccwalk.ca to learn more. So thank you, Dr. Wong, again for sharing this information with us. And thank you to everyone who attended. I hope you have a great night.